Good afternoon. Today I'm going to discuss most important messages about the heart and kidney crosstalks. Last year, I recorded these two presentations and basic informations and advanced informations about heart and kidney relationships. So please, before listening to this video, to review these two videos. So today, I'm going to highlight some points in introduction, followed by few points linking the heart and cardiovascular system with acute kidney injury, chronic kidney disease domains, and I'm going to concentrate on the most important risk factors in chronic kidney disease that can touch cardiovascular system, and a few slides about dialysis and renal transplantation before I'm reaching the last sector, which is oncology and cardiorenal affection, and lastly, the final message. Let us start. Always, I like to start my presentation by epidemiological data, and usually I use United States Renal Data System. Today, I'm going to shift to China. So it is China Kidney Disease Network that was released on March early this month in this special kidney international supplement, and the summary of this supplement is released within the Journal of Kidney International March 2000 this year. So if you look at the China Chronic Kidney Disease Network, you will find here this data: prevalence of cardiovascular disease stratified by patient group. So this is the bar system reflects the percentage of patients who have cardiovascular disease, and we have cardiovascular disease, coronary heart disease, stroke, heart failure, and the atrial fibrillation. Please look at the color code. The yellow color reflects patients who have chronic kidney disease. Red color, diabetic patient, and the other color, green color, is non-chronic kidney disease patients. What do you see? Coronary heart disease is significantly higher in CKD and diabetes in comparison to non-chronic kidney disease. The same for stroke, the same for heart failure and atrial fibrillation. So, chronic kidney disease and diabetic patients are unlucky because they have increased the risk of coronary heart disease, stroke, heart failure, and atrial fibrillation. If we go to the number of patients as detailed in this table, we have diabetic kidney disease, hypertension. All these are the causes of chronic kidney disease, glomerulonephritis, chronic tubular interstitial nephritis, obstructive nephropathy, others, and the total number of patients included. And you can look at the number and the percentage of coronary heart disease, stroke, heart failure, and the atrial fibrillation. Again, you will find here in diabetic patient and hypertensive patient, the risk is higher for coronary heart disease, stroke, heart failure. So this is very nice data documenting the link between kidney and the cardiovascular system. If we look at the gender, male and female, is there a difference? You can see to this bar system through the different spectrum of the causes of chronic kidney disease. You will find the percentage of patients with coronary heart disease. In the red color means male, the other color female. So you can see both male and females suffer from cardiovascular disease, from coronary heart disease, if they are diabetic and hypertensive. The same for stroke, for heart failure, And this is a very nice table because it reflects in-hospital mortality rate stratified by chronic kidney disease, diabetes, and heart failure. If we look at patients who have nothing, no chronic kidney disease, no heart failure, no diabetes, mortality rate is just 0.6%. Suppose that we have only CKD, mortality rose to 1.6. But if there is heart failure, it is 4.2. Suppose that we have both chronic kidney disease and heart failure, it becomes very high, 8%. So this demonstrates the importance of cardiovascular disease in our patients. This is the disease-specific risk enhancer for cardiovascular disease. As you see, this is a diabetic patient. If diabetic patient has albuminuria or reduction of estimated GFR, albuminuria above 30 milligram per gram or microgram albumin per milligram creatinine, or estimated GFR less than 60 milli per minute, these two criteria are within the diabetic specific risk factor enhancer for cardiovascular disease. Back to United States Renal Data System, and this is a very nice slide because it reflects different age ranges. If you just look at the green color reflects young group of patients between 22 to 44. What do you see? At least 50% of young patients on hemodialysis suffer from cardiovascular disease. If you go to a higher age range, like 60 plus, you will find even the risk exceeds 70%, and for those above 75, more than 80% of hemodialysis patients have cardiovascular disease. So this is bad news. Chronic kidney disease and dialysis patients are associated with cardiovascular disease. Let us go to this an interesting article. What about the young generations? We have child, adolescent, and young adult. These are the number of persons within each category. This is the 2,800 children, 10,000 adolescents, 20,000 young adults. What's your expectation? The question of this research, do young adults with incident end-stage kidney disease have different risks for cardiovascular disease than patients in younger age group, either child or adolescent? The answer from the study, what do you see? This is the hospitalization because of cardiovascular disease. So the cardiovascular disease hospitalization per 1,000 patient for patients with incident end-stage renal disease. The age category between 22 to 29, as you see, have the highest cardiovascular disease hospitalization. This is to say, per this analysis, young adults with incident end-stage kidney disease have cardiovascular disease risks and outcomes that differ from other age group, suggesting a need for age-appropriate research and management strategies. Again, the same in China. This is dialysis patient, and the prevalence of cardiovascular disease in dialysis patients by modality and age and gender. Here we have hemodialysis, peritoneal dialysis. You will find the percentage is clear. We have higher cardiovascular disease either in hemodialysis or peritoneal dialysis according to all age spectrum. In dialysis, as you see from this pediatric literature, the environment of dialysis is full of many risk factors, either traditional or non-traditional risk factors for cardiovascular disease. So you can find the primary disease responsible about renal failure, intestinal dysbiosis accompanying hemodialysis, the presence of uremic toxins, infection, oxidative stress, metabolic acidosis, vitamin D deficiency, FGF23, the presence of cachexia, anemia, chronic kidney disease, mineral bone disorders, vascular calcification, chronic inflammation, all these environment factors will lead to cardiovascular morbidity and mortality. And this is the risks and mechanisms. Here you'll find cardiac disease, microvascular disease, arterial disease, in chronic kidney disease, and on dialysis. So you can find for the heart, left ventricular hypertrophy, altered mechanics, myocardial stunning, left ventricular dysynchrony, and for microvascular disease, microvascular rarefaction, endothelial dysfunction, and tissue hypoxia. All these are factors that can lead to microvascular disease. Here, CKD, MBD, and other the spectrum of inflammation, cachexia, dyslipidemia, hypertension, hypoalbuminemia in dialysis environment, fluid overload, intradialytic hypotension. So a cocktail of factors that can increase the risk for the cardiovascular disease. And today we have what's meant by MERS. Do you know MERS, Muhammad? It is MACE is very famous, major adverse cardiovascular events. But what about MERS? MERS is a merge of MACE with renal. So major adverse renal and cardiovascular events. What are the components of MERS as outcome? Here you may have acute renal failure, renal replacement therapy, progression of chronic kidney disease. So this is the renal component of MERS. Stroke, myocardial infarction, hospitalization, heart failure, and mortality as a consequence of both. So this is the MERS. Regarding acute kidney injury, I'm not going to discuss acute kidney injury, but I'd like to highlight this article because this is a very nice article. Double-blind randomized control study addresses a very important question for the cardiologist. What about using fluids to protect against contrast-induced nephropathy when we think of angiography? This is an article for angiography, either coronary or non-coronary angiography. And here, this is a number of patients in each arm. So we have sodium bicarbonate arm, sodium chloride arm. So sodium bicarbonate is compared to sodium chloride in this number of patients, and acetylcysteine to placebo. So it will answer the aim of this study is to answer a question: is there a superiority for sodium bicarbonate on sodium chloride, and the same is acetylcholine of value in comparison to placebo? The answer is, if you look here, this is the endpoints, either primary or secondary endpoints. There is no difference at all in the p-value between sodium bicarbonate or sodium chloride. So there is no advantage to use sodium bicarbonate. And the same, and it is very, very surprising information, no advantage to acetylcysteine in comparison to placebo. And the analysis of the data according to the performance of primary coronary intervention, percutaneous coronary intervention. So here we have PCI group 1,100 and no PCI 3,300. And here, as you see, the comparison between bicarbonate and saline, comparison between N-acetylcysteine and placebo, for both primary endpoints and secondary endpoint, again and again, the same data, no superiority of bicarbonate on the saline, and N-acetylcysteine doesn't add anything. So intravascular volume expansion with isotonic sodium chloride should be considered the standard of care for prevention of adverse renal outcome when we think of doing coronary intervention for our patients with chronic kidney disease. Regarding CKD domains, Hypertension is one of the important factors in progression of chronic kidney disease. So in this core curriculum, what are the causes and the pathophysiological mechanisms of hypertension in the presence of chronic kidney disease? Pathophysiology of hypertension is quite complex. Here, in chronic kidney disease, we have reduced glomerular mass with subsequent endothelial dysfunction, increased renal production, decreased sodium excretion, excessive sympathetic activity, increased the angiotensin system, sodium retention, increase the peripheral vasoconstriction. At the end of the day, we have arterial stiffness, volume expansion, and increased blood pressure. So as you see, pathophysiology of hypertension in chronic kidney disease is quite complex. One important message that I like to conduct, and I always stress upon how to measure blood pressure in office. So this study, this is the, as you see, meta-analysis for 31 articles comprising 9,000 participants, and this study showed automated office blood pressure measurement should replace the recording of blood pressure by nurses and physicians in routine practice. So either to use automated office blood pressure, or I am myself is convinced by the home blood pressure. Regarding the type and the selection and the prescribing orders of antihypertensive medications in the presence of chronic kidney disease, the drug in the first order is either angiotensin converting enzyme inhibitors or angiotensin receptor blocker. This is the first choice, followed by either dihydropyridine calcium channel blockers or diuretics. Third drug is either to use diuretic or dihydropyridine calcium channel blocker, and the fourth drug to be mineralocorticoid receptor blockers. So this is the order of prescription of antihypertensive agents in chronic kidney disease based on the level of evidence. So let us just go to highlight mineralocorticoid receptor antagonist. If we have active aldosterone, it will stimulate mineralocorticoid receptors. Mineralocorticoid receptors, when it's activated, it affects kidney, heart, blood vessel, and brain. So in kidney, mineralocorticoid receptor activation is associated with electrolyte imbalance, hypokalemia, sodium and water retention, proteinuria, glomerular injury, vasoconstriction. In heart, fibrosis, apoptosis, inflammation. Blood vessels, increased endothelial dysfunction, decreased the nitric oxide bioavailability and fibrosis. In brain, increased sympathetic nervous system activity. All the product of these systems affection will lead to hypertension, heart failure, and chronic kidney disease. So this is the value of exaggerated mineralocorticoid receptor activation. So if we use a mineralocorticoid receptor antagonist like spironolactone, eplerenone, or finerenone, these mineralocorticoid receptor antagonists will ameliorate these bad effects on different organs, including kidney and heart. Is it clear? Regarding spironolactone in chronic kidney disease, this is a nice study, double-blind randomized control trial to study the efficacy and the safety of spironolactone in patients with heart failure with preserved ejection fraction and chronic kidney disease. The results are assuring toward the efficacy, but the most important is, so if you look at the efficacy regarding cardiovascular death, hospitalization, and cardiac arrest, this is if you have preserved estimated GFR, as you see, events were more common in placebo in comparison to spironolactone. So spironolactone is effective in reducing cardiovascular events in the presence of preserved GFR. Okay, but the problem when GFR is less than 45, what happens here? The incident rate of hyperkalemia is more common in patients with advanced CKD. So we should put it in our mind. Here, this is the GFR. If the GFR is preserved, you will find difference in events, so it is effective, and it's tolerated because discontinuation rate will be low. But with reduction of GFR, what happens? There is excessive discontinuation because of hyperkalemia. So the message is spironolactone is beneficial in presence of chronic kidney disease and heart failure, but be careful about hyperkalemia. If you would like to use this drug in the presence of CKD, potassium should be monitored. Okay? What about different generations of mineralocorticoid receptor antagonists? Look here, we have 3 generations. First generation is spironolactone. Second generation is eplerenone. Third generation is finerenone. What are the differences between these 3 generations? The differences are in selectivity for mineralocorticoid receptors. You'll find here the third generation finerenone is more selective. Affinity for progesterone and androgen receptors. And if there is affinity for androgen receptor, you can expect gynecomastia and side effect. Here, it is higher with spironolactone and less with the third generation finerenone. Gonadal axis related side effects, gynecomastia, impotence, breast tenderness, menstrual irregularities, all these are common with the first generation and less with the third generation. Hyperkalemia side effects is also less in the third generation. So it seems that the tolerability of the newer third generation finerenone is better than the old generations, and we are waiting ongoing trials to prove the efficacy of finerenone on the outcome. Regarding the target of blood pressure control in the presence of chronic kidney disease, this is the European guidelines that was released August last year. If we are in the CKD domain, we would like blood pressure to be reduced first to less than 140, then to 130 if tolerated. Okay? And diastolic blood pressure to be less than 80. So this is 130 over 80. This is the end result. And this is the same target recommended by the American guidelines. In diabetes, targeting 130 but not less than 120. Because if we intensify systolic blood pressure to less than 120 in diabetic patients, this will increase the risk of chronic kidney disease and side effects. The European guidelines also recommended from the starting point to start with a combination build. So dual therapy, either using ACE or ARB plus either calcium channel blocker or diuretics from the starting point. And the loop diuretic is used if estimated GFR is less than 30 ml per minute. And then you can add the third and fourth drug as we discussed before. Beta blockers are only considered when there is compelling indication like heart failure, angina, or post myocardial infarction. So this is the situation of treatment of chronic kidney disease. Regarding diabetes, diabetes is one of the common causes of chronic kidney disease, and diabetic kidney disease is very important and associated with many cardiovascular outcome problems. And the treatment of diabetes in the presence of cardiovascular diabetes is changed from just treating hyperglycemia is to avoiding and amelioration of the cardiovascular risk factors and to avoid the atherosclerotic consequences as shown from this meta-analysis. There is superiority of using sodium glucose cotransporter 2 inhibitor as to protect kidney and heart. And this is what is stated in 2019 American Diabetes Association standard of care for diabetes is first after giving metformin and lifestyle modification, assess the presence of cardiovascular or chronic kidney disease risk. If there is atherosclerotic cardiovascular predominate, think of glucagon-like peptide 1 receptor agonist with proven cardiovascular disease benefit. And here or sodium glucose transporter was proven cardiovascular benefit if estimate GFR allow, because below certain GFR we cannot prescribe sodium glucose transporter 2 inhibitors. If there is heart failure or chronic kidney disease predominate, here preferably to use sodium glucose transporter 2 inhibitor if estimated GFR allow. But if sodium glucose transporter 2 inhibitor is not tolerated or contraindicated for estimated GFR less than advised, we can shift to glucagon-like peptide 1 receptor agonist. So here, after lifestyle modification and metformin, we should think of cardiovascular and chronic kidney disease. So this is the first time for American Diabetes Association to put this statement clear in their guidelines. What about empagliflozin, which is sodium glucose cotransporter 2 inhibitors? Empagliflozin is associated with, as you see here, with lower risk of post-acute heart failure, rehospitalization, and mortality, as shown from this study. So we have the black one is empagliflozin, and the lighter one is placebo. So heart failure rehospitalization, as you see, is significantly reduced by the use of empagliflozin. Cardiovascular death or heart failure rehospitalization also is significantly reduced through these days with the use of empagliflozin. Any death or heart failure rehospitalization is also significantly reduced by using empagliflozin. And this is another study showing that empagliflozin reduced the mortality and hospitalization for heart failure across the spectrum of cardiovascular risk factors in the EMPA-REG outcome trial, or irrespective to the cardiovascular risk, empagliflozin works well. And this is a very nice comment about empagliflozin, because it may be combined with other drugs. Here, if it is the non-steroidal drugs, as you see, the non-steroidal inhibit production of renal vasodilator prostaglandin, and it leads to constriction of afferent arteriole, abolishing renal autoregulation. This is sodium glucose cotransporter 2 inhibitors block reabsorption of sodium and the glucose in the proximal tubule, lead to natriuresis, increase the sodium reaching macula densa, restoration of tubulo-glomerular feedback, and lead to vasomodulatory effect and constriction of afferent arteriole, as you see, potentially improve kidney autoregulation. ACE inhibitors or angiotensin receptor blockers reduce angiotensin 2 activity primarily at the efferent arteriole. So ACE inhibitors or ARBs lead to dilatation of efferent arteriole. Thiazide diuretics inhibit sodium chloride cotransporter in distal tubule, not expected to directly alter renal hemodynamic. Why? Because it works below macula densa. So calcium channel blocker, except here in thiazide, if volume depletion, volume reducing effects may indirectly impact renal hemodynamic parameters. Calcium channel blockers modulate the arterial tone by blocking L, N, or T type of calcium channels that can lead to dilatation of afferent arteriole only, or afferent and efferent arterioles. Regarding loop diuretics, and this is to be put in mind, loop diuretics works on ascending limb of Henle. So it may play, it may attenuate the effects of empagliflozin because the loop diuretics increases natriuresis before macula densa. However, it was shown that empagliflozin has some beneficial effects with even the use of all these drugs. Holistic approach is my recommendation for treating diabetic kidney disease. We shouldn't concentrate on plasma glucose alone. So we look at the panoramic view of diabetic kidney disease. So we should control hyperglycemia, dyslipidemia, and hypertension and other risk factors. This slide is very smart. I like it, and I repeat it all the times when I discuss diabetic kidney disease. We have diabetic kidney disease, and we have diabetic kidney disease, and we have cardiovascular disease. Okay, so if you look here, there is for anti-hyperglycemic measurement, we have sodium glucose cotransporter 2 inhibitor. The line is solid. This means there is solid evidences for potential effects on diabetic kidney disease and cardiovascular disease. The same for GLP-1 receptor agonist. The same for mineralocorticoid receptor blockers, ACE inhibitor, and ARBs. But when you find any interrupted line, this means the evidence is debated. Okay, statin has solid line with cardiovascular disease, but no line with kidney disease. This is why statin is only beneficial for the cardiovascular system. Regarding statin, does intensity matter? Do you recommend high-intensity statin while we are treating chronic kidney disease patients? This was the question of this study. As you see, this is the statins according to their intensity. This is the famous atorvastatin and rosuvastatin in this dose range. Atorvastatin 40 to 80 or rosuvastatin 20 to 40 have a high-intensity effect. High-intensity means they have the capacity to reduce LDL by more than 50%. In this table, you'll find simvastatin 80 milligram is also added according to one of references. But the famous is high-intensity statins are either atorvastatin or rosuvastatin in this dose range. Moderate intensity statin to reduce LDL between 30 to 50%, atorvastatin between 10 to 20, rosuvastatin from 5 to 10, or other statins in this dose. Low intensity statins are either Semva 10 milligram, pravastatin 10 to 20, lovastatin, fluvastatin, or this statin in this dose. As you see, in atorva and rosuvastatin are either moderate or high intensity according to dose range. They are not low intensity at all. Okay? The question is, do we recommend in chronic kidney disease to use high intensity statin as dedicated from the cardiology guidelines? Actually, this study shows no superiority to high intensity statins in the presence of CKD. So we should review this matter, and we are waiting studies in chronic kidney disease. Up to this moment, we don't recommend high intensity statin in the presence of advanced stages of CKD. Regarding statins, this is if you look at this take-home figure of this article, there are benefits and the potential risk. As you see, benefits outweigh the potential risk. Potential risks of statin included modest risk of new onset diabetes, muscle symptoms, very rarely clinically relevant liver injury, possible increase in risk of hemorrhagic stroke in patients with a prior stroke suggested by this, not confirmed in the subsequent evidence base. Benefits of statin prescriptions include reduction of LDL, regression of coronary atheroma, and reduction of atherosclerotic vascular events. This is a recent meta-analysis including 94,000 participants addressing the issue comparative effectiveness and the safety of statins as a class and specific statins for primary prevention of cardiovascular disease. As you see, and as we all of us agree, the statin use is superior to protect the cardiovascular system. No doubt of that. But as a nephrologist, look here, there is a favor of control. This means that statins may be associated with little bit increased renal risk. If I ask you, which is safer, rosuvastatin or atorvastatin, you will be surprised when you know that atorvastatin is safer for the kidney than rosuvastatin. So atorvastatin is more safer than rosuvastatin. If you have chronic kidney disease and you think of ischemic heart disease or the cardiac biomarker used in the presence of chronic kidney disease, this is troponin. Troponin, it is released from cardiac muscle cell, troponin T and I, cardiac troponin T and I, physiological function involved in muscle contraction by binding to calcium and exposing actin binding sites. Kidney extraction index between 8 to 20%, reduced urinary clearance in chronic kidney disease, doesn't significantly impact elevated troponin in setting of cardiac ischemia. A diagnostic value in the presence of chronic kidney disease, troponins retain high sensitivity to rule out cardiac ischemia in CKD. Trending, this is the most important point, is to repeat after 6 to 9 hours, several hours, to look at the trend. Rising trend is diagnostic in the presence of chronic kidney disease. So elevated troponin levels indicate poor prognosis and higher mortality in chronic kidney disease patients from prognostic point of view. Regarding BNP, it is from ventricular cardiomyocytes. It's associated with natriuresis, diuresis, and vasodilation. Kidney extraction index between 15 to 20%. A rollout cutoff less than 200 to 225 nanogram per liter is suggested to exclude heart failure in chronic kidney disease patients versus less than 100 in normal kidney functions. So the prognosis, elevated levels of BNP and NT-pro-BNP are strongly predictors of short and long-term mortality. This table summarizes the relatively newer biomarkers that can be used. This is the SGLT2. It is suppression of tumorigenicity 2. And here gross differentiation factor 15, galectin 3, matrix glyprotein, uncarboxylated matrix glyprotein, dephosphorylated uncarboxylated matrix glyprotein, and you are waiting further studies for these biomarkers. But the superiority of SCT here, SCT doesn't appear to be influenced by kidney function. Okay, so we are waiting further studies for these points. Regarding decision making, how to treat patients with, how to treat ischemic heart disease in the presence of chronic kidney disease, by medical treatment or coronary intervention or surgery, CABG operation. What do you think, Muhammad?
I think medical treatment has the superiority.
Okay, look at the data. So we have here 3 categories of patients: preserved estimated GFR, mild chronic kidney disease. Mild means between 60 to 90 milli per minute, and the moderate chronic kidney disease between 60 to 30. Okay, and then look here. If we have preserved kidney function, estimated GFR is normal. This is the reference point. If you have mild chronic kidney disease, the crude hazard risk increased by this point, although it's insignificant. But in moderate chronic kidney disease, if estimated GFR is less than 60, between 60 to 30, the crude hazard risk increased to 1.7, it is significant, and the adjusted is also significant. So this means that presence of chronic kidney disease is bad news for combined events and including death and myocardial infarction. For death, the same. The presence of chronic kidney disease is bad news, either moderate, so either unadjusted or adjusted. You will find significant increased death. For myocardial infarction, it doesn't work as it works with mortality. So the first point is the presence of chronic kidney disease for patients who have ischemic heart disease is bad news and associated with increased combined events and death. Okay, let us concentrate on the question: which modality we will select? Medical therapy, CABG, or primary coronary intervention? If you look here, in the presence of preserved GFR, according to the patient's characteristics, everything is fine. But with mild chronic kidney disease, what do you see? Combined events in PCI is 29%. Here in CABG, 29%. But for medical therapy group, 40%. So medical therapy is associated with worse outcome. Death, 24%. 19%, 28%. Again, medical therapy is inferior to either BCI or CABG operation. Look at this. So 24% in comparison to 9 or 12%. So the key message, if we have mild chronic kidney disease, don't deprive the patient from coronary intervention. If the risk stratification is state doing primary coronary BTCA or CABG operation can be done, and we shouldn't deprive them because medical treatments are associated with worse outcome. Even in moderate chronic kidney disease, although no significant difference, but look at number. Combined events here is 50% in medical treatment. Here it is 44. Here 14.8 higher than CABG operation. So we shouldn't deprive chronic kidney disease patients from intervention whenever intervention is necessary. Okay, and this is just repeating the data, confirming the statement. This is a comparison risk of events and its components of CABG compared to medical therapy in different renal function strata. Again, as you see, the adjusted others here, what do you see? For CABG overall, it is less than 1. It's significantly lower in CABG in comparison to medical treatment. This, the same, less. So don't deprive the patient. If there is, and this is, you can fix this slide and look at mild CKD. Mild CKD, it is less than 1. Less than 1. So again, don't deprive the patient from CABG if CABG is indicated. For BCI, the same. So either BCI or CABG operations are superior to medical therapy. Okay. In dialysis patients, we prefer PCI if anatomy allows, using drug-eluted stent, and leave CABG as a second line of treatment. This is a new drug. Do you know lipoprotein A1? It's an important component within HDL, and it is responsible about the function of HDL. So this is a paradigm shift. And instead of concentrating on increasing level of HDL, to increase and improve its function by using apolipoprotein A1, which leads to cholesterol efflux system. So this is for weekly infusions of 60 grams of this apolipoprotein A1 among AMI, acute myocardial infarction patients with moderate chronic kidney disease. And we are waiting further studies in this point. It's a very smart slide. Why smart slide? In this slide, you will review all evidence base for goal therapy for heart failure in the presence of kidney disease. The best treatment is beta blocker, because beta blockers has strong evidence in either in mild and moderate chronic kidney disease, and moderate evidence for superiority in severe chronic kidney disease. So beta blocker on the top, followed by S and or ARB. Why? Because S or ARB, the same evidence in mild and moderate chronic kidney disease, but in severe CKD, it has this group has weak evidence. In beta blocker, it was moderate. There is no room for nitrate or digoxin. The evidence is weak all through the different range, different kidney functions. Weak, absent. Okay, and this is resynchronization, cardiac resynchronization, implantable cardioverter. You'll find the evidence for them in mild and moderate chronic kidney disease. For diuretics, also the evidence is absent for beneficial effects irrespective to the kidney function. So it is very nice. So we should advocate the use of beta blocker S inhibitor. If you look at the mineralocorticoid receptor antagonists, yes, they have strong evidence up to stage 3 CKD, but the evidence is absent in stage 4 and 5. ARNI is the new class of drugs, neprilysin inhibitors, here strong and absent in advanced stage. Regarding replacement therapy, for dialysis patient, cardiovascular disease is very prevalent, as I mentioned in the introduction sector, because of the problems of uremic toxin, chronic kidney disease, CKD, MVD profile, cardiovascular calcification, all these, atherosclerotic endothelial dysfunction, all these can lead to myocardial cardiovascular disease. What about selection of antihypertensive in dialysis patients? This is the order of prescription of antihypertensive in dialysis. It is completely different from CKD. In CKD, we say ACE inhibitor or ARB, followed by dihydropyridine calcium channel blocker or diuretics, and lastly, mineralocorticoid receptor blocker. Here, the beta blocker is the drug of choice. So beta adrenergic receptor blocker is the drug of choice, followed by dihydropyridine calcium channel blocker. ACE or ARB lie in the third order, and lastly, direct vasodilator. Regarding beta blocker, whenever you have a patient treated with beta blocker and he has intradialytic hypertension, think of changing beta blocker from dialysable one like atenolol to non-dialysable or minimally dialysable drug, which is carvedilol. Okay, and there is another an important study that showed that metoprolol even superior to carvedilol, because the study documented increased mortality because of increased intradialytic hypotension with carvedilol. So I think carvedilol is superior if there is intradialytic hypertension. Spironolactone affects all these points as I mentioned before, so it has a good cardiovascular profile, but we are afraid in the presence of renal failure from hyperkalemia. We have two studies here in hemodialysis, SPENDI and Miranda study. Although both studies didn't reveal positive impact on cardiovascular system, but they give us a trust of using the drug in a dose of 25 milligram. So spironolactone, if it is used in dialysis patients, should be used in a dose of 25 or less milligram, because 50 milligram is associated with hyperkalemia, and we are waiting the ongoing trials that include large number of patients, because Miranda and SPEND-D study are studies with few patients, and the main aim is to assess tolerability. Regarding mesenteric ischemia and its correlation with intradialytic hypotension, so intradialytic hypotension is a very common problem in hemodialysis, and this is the group of patients. We have 600 with mesenteric ischemia, 2,000 without mesenteric ischemia, and here mesenteric ischemia was correlated with intradialytic hypotension. Hypotension is either defined by the nadir blood pressure less than 90, less than 100, or fall 20 millimeter mercury, fall 30, fall nadir 90 and fall 20, nadir 90 and fall 30. As you see, the black colored refer to mesenteric ischemia. Okay, so mesenteric ischemia is associated with the nadir 100 and nadir 90. Okay, how to deal with intradialytic hypotension? With cooling of dialysate to a tolerable level. So just reduce dialysate temperature by half degree to avoid shivering, and reduce interdialytic weight gain. So we should encourage the patient for proper drinking and to salt restrict and to enhance dialysis for these patients and avoid excess ultrafiltration. Other parameters like levo, L-carnitine, this is debatable, and sodium profiling is not recommended to reduce intradialytic hypotension. Vascular calcification. In dialysis, there is excess we have inhibitors and promoters. In dialysis, there is excess promoters of vascular calcification. And this slide shows inhibitors and promoters of vascular calcification. So in dialysis, promoters are in excess. So vascular calcification promoters, it change the contractile vascular smooth muscle into bony forming cell, leading to vascular calcification and problem. And here, as you see, we can deal with vascular calcification by targeting many pathways, but I am interested in vitamin K pathway because vitamin K is essential for carboxylation and phosphorylation of matrix glyprotein. So matrix glyprotein is important to be carboxylated and phosphorylated. If it is carboxylated and phosphorylated, it will lead to avoidance of vascular calcification. So we have vitamin K dependent protein. We have matrix glyprotein and we have ostocalcine. So vascular and in the presence of excess vitamin K, carboxylated ostocalcine will lead the calcium to go to bone and avoid vascular calcification. So carboxylated matrix glyprotein is essential to avoid vascular calcification, and the carboxylated ostocalcine is to calcify bones. If vitamin K is deficient, uncarboxylated ostocalcine and uncarboxylated matrix glyprotein will increase the risk of vascular calcification. So we can measure uncarboxylated matrix glyprotein. If it is high, we may think of vitamin K or vitamin K2. Regarding blood pressure, pulse pressure, and mortality in hemodialysis patients, what about the interaction with heart failure and the atrial fibrillation? This study shows a very interesting data. If there is no atrial fibrillation or heart failure, the higher the pulse pressure, the higher the risk for cardiovascular events and mortality. Okay? And here, if you have atrial fibrillation or heart failure, the reverse occur. The lower the pulse pressure, the higher the hazards for mortality. Is it clear? Okay. Post-transplant hypertension. This is one of the cardiovascular problems after transplantation. So we categorize our patients. If we are dealing with arrhythmias or coronary artery disease, we like and prefer beta blocker. If heart failure or overload, diuretic ACE inhibitors and beta blockers. If the associated proteinuria, ACE or ARBs. If there is antibodies against angiotensin 2, we may think of losartan as angiotensin receptor blocker to avoid the immunological phenomena. DASH, diet approach to stop hypertension. We learned from this article to encourage DASH, to encourage fruits and vegetables. Why? Because, as you see, the lower DASH score, this means the lower fruits and vegetables consumption, the higher the risk for all-cause mortality and deterioration of graft function. And this is, so we should encourage fruits to our transplant patients. Regarding oncology, this is immune checkpoint inhibitors, and I recommend these 3 articles because it give idea about cardiorenal complications of immune checkpoint inhibitor in these articles, and this is 2 articles for immune checkpoint in cardiovascular toxicity and this renal complication. So these 3 articles are highlighting the cardiovascular risks of immune checkpoint inhibitors. To simplify, we have cancer, okay? So tumor either releases ligands like PDL1. This is a program, this ligand 1. On lymphocytes, there is receptor BD1. BD1 is inhibitory for lymphocytes, so increases the exhaustion of T cell. When it binds to ligand from tumor, T lymphocyte will be inhibited, and this will allow tumor to flourish. The same, we have co-stimulation here and co-inhibitory here. So CTLA4 on the lymphocyte, when bind to its ligand, it leads to inhibition of T cell. So if T cell is inhibited, tumor will flourish. So this is why we have drugs either to block BD pathway. So when BD pathway is blocked, T cell will be activated, or CTLA4 pathway. So we have this monoclonal antibody, ipilimumab, against CTLA4, and it is tested in melanoma. Nivolumab, PD1, targeting PD1. It is human monoclonal antibody against PD1, and can be used in colorectal, head and neck, liver, lung cancer, kidney, melanoma, urothelial malignancies, and as you see, other checkpoint inhibitors, and this is targeting in the ligands, and this is PD1. So, and all these drugs are FDA approved. What is the problem? When we inhibit inhibitory pathways of T lymphocyte, we will stimulate lymphocytes. What are the side effects of stimulating lymphocytes? We may have immunological related side effects. So these activated lymphocytes may hurt kidney and may hurt heart. Let us focus on the heart. So the managing cardiotoxicity. Before managing cardiotoxicity, what are the percentages and the distribution of side effects on the heart? We may have myocarditis, pericardial disease, conduction abnormalities, or stress cardiomyopathy. So this is the, if you look at nivolumab, so there are 148 cases reported about myocarditis. Total number of myocarditis in for check inhibitors 300 cases, and myocarditis may be mild or may be so severe. So the presentation can be challenging, can present with heart failure, pulmonary edema, cardiogenic shock, multi-organ failure, ventricular arrhythmias. And so we should be energetic to treat the disease. If the disease is mild, we can think of giving a mild immune suppressive drug like steroid. But if the disease is severe, we should stop immune checkpoint inhibitor. So stop immune checkpoint inhibitor depending on the severity of the toxicity. And then if toxicity is severe, we should give methylprednisolone pulses, as you see here. Moreover, followed by prednisolone, and we may give mycophenolate, infliximab, and thiamethyl globulin, intravenous immunoglobulin, and use the other plus the treatment of the syndrome from cardiology side. So as you see, if you are consulted in the oncology department about cardiac problems, you should review the medications and to know how to deal with this medication. My final messages: we should shift from treating diseases to prevent disease. I agree totally with this very recent guidelines from American College of Cardiology that was released this month on 17 March. And in this 76 pages, here the stress on prevention. So if we take type 2 diabetes as example, as you see, it is 1A evidence, strong evidence for recommendation for all adults with type 2 diabetes, a tailored nutrition plan focusing on a heart healthy dietary pattern is recommended to improve glycemic control, achieve weight loss if needed, and improve other atherosclerotic cardiovascular disease risk factors. Adult with type 2 diabetes should perform at least 150 minutes per week of moderate intensity physical activity or 75 minutes of vigorous intensity physical activity to improve glycemic control, achieve weight loss if needed, and improve other atherosclerotic cardiovascular risk factors. But we should tolerate exercise according to the patient tolerability. For adults with type 2 diabetes, it is reasonable to initiate metformin as first line therapy, along with lifestyle therapies at the time of diagnosis to improve glycemic control and reduce atherosclerotic risk. For adults with type 2 diabetes, additional atherosclerotic cardiovascular risk factors who require glucose lowering therapy despite initial lifestyle modification and metformin, it may be reasonable to initiate sodium glucose cotransporter 2 inhibitor or a glucagon-like peptide 1 receptor agonist to improve glycemic control and reduce cardiovascular disease risk. And this is fantastic slide from the Lancet about the carbohydrate. We should know the carbohydrate. We should know what is carbohydrate. Quality of carbohydrate does matter. And this is in this meta-analysis, if you look here, this is for fiber. The higher the fiber, the higher the beneficial effect. And as you see here, the higher fiber, total fiber in carbohydrate, is associated with moderate quality evidence for reduction of all-cause mortality. And this is the number of cases and the person per year, as you see, big data. Moderate evidence for potential benefit effect on coronary heart disease, moderate beneficial effect on coronary incidence. So this is the coronary heart disease mortality and coronary heart disease incidence. For stroke, it is very low. For type 2 diabetes incidence, to prevent diabetes, if you use high fiber, it has a preventive effect against diabetes and against cancer. So again and again, if you use carbohydrate of high total fibers. This is for observational studies, and for randomized studies, a change in body weight will be high. There is high evidence, high quality evidence towards superiority of total fiber, and this is the and change in total cholesterol and change in systolic blood pressure. The evidence is moderate, but for glycated A1C, the evidence is low. And as you see, all for total fibers, mortality will be reduced, coronary heart disease will be reduced, type 2 diabetes will be reduced, colorectal cancer will be reduced, and for carbohydrate, whole grain is better than other styles, so it will affect it will be beneficial for mortality and other diseases. And this is, as you see, in favor of high fiber intake, in favor of whole grain than lower whole grain. And myself, I'm interested in cardiology, and this is why we bought and we are interested in BOCUS. BOCUS is point of care ultrasound, including echocardiogram, abdominal ultrasound, etc. And as you see in our courses for African countries, we bought the workshop for echocardiogram because a nephrologist should know how to pick up pericardial effusion, valvular movement, myocardial performance in a very quick manner, and leave the details for cardiologists. To finish the presentation, I'm always proud of this site because it is expanding every minute, and this is the harvest 3,800 lectures and videos and everything you can reach in a smart search. And one of important message to conduct when you deal with the patient, it's better to deal in a team approach, multidisciplinary team approach. This is what I learned from our team at Mansoura Urology and Nephrology Center. And my last statement is we should keep keep ourselves educated, because doctor is a student until he dies. Once he considers himself not a student anymore, the doctor inside him dies. Thank you very much. Hoping you the best, and I'll be happy if you have any questions to send to my email. Goodbye.